Well, welcome everybody to NHS Newark Sherwood Clinical Commissioning Group's annual general meeting. This is our first annual general meeting after being fully authorised as an NHS statutory body, which occurred in April of 2013. It's great to see so many people here, and it is a very warm welcome. I very much appreciate people giving up their time to let us have the opportunity to discuss what we've done over the past year or so, what we're going to be doing over the next sort of year to 5 years, and also use this as an opportunity to take questions from our patients and public, and for discussion to take place with the officers and myself back to public regarding issues that people may need to raise or want more clarification on. For those of you that don't know me, my name is Dr. Mark Jefford. I'm a GP at the Fountain Medical Centre over in Newark, and I'm also the clinical chair of the governing body for Newark and Sherwood, CCG. So my time's split between about 3 days in practice clinically every week and about 2 days working for the CCG. Just an overview of today. We're going to start off with Dr. Amanda Sullivan, our Chief Officer, who's going to talk about a general overview of the CCG and also the Better Together programme. I will then talk about improving the NHS in Newark and Sherwood and some of the key achievements we've had over the past couple of years or so. We've got a couple of films that have interspersed just to sort of change the flavour a little bit, and just that talks a little bit more about sort of what we've been doing, where we're going in the future, and also involves a lot more clinicians and officers than we have here today, so that you can hear about the other work that's going on behind the scenes. We then have Mr. Simon Crowther, who's our Chief Financial Officer, who will be summarising a report of the financial accounts for the last year. And then Elaine Moss, who's our Chief Nurse and Director of Quality, will be talking about quality and experience for patients. Robert Ferris-Rogers will then be talking about the future and our plans for the future. And then we'll have a question and answer session for about half an hour towards the end there. So I will now hand over to Dr. Amanda Sullivan, who's our Chief Officer, to talk about the overview of the CCG.
Thank you very much. And just to reiterate Mark's thanks to you all for coming and spending some time with us this morning. It's really great to see a number of you here. And we do have a further sort of repeat of this event next week over on the Sherwood side of our patch. So we're looking forward to hopefully seeing some more people there as well. So the CCG is a partnership of 15 practices that works across Newark and Sherwood. And because it is quite a wide geographical area and there is variation within that, that is divided into 5 constituencies that are all represented by an elected GP onto our governing body. And we serve 128,000 residents as a whole, with an annual budget of about £150 million, so a considerable resource to spend on healthcare, but never as much as we would like. When we set up the CCG, it was very different, very much led by local clinicians, and the value base that we have by which we work has been really sort of embedded into how we make decisions and the types of services that we commission. So very much around valuing honesty and integrity and transparency. So sometimes we may not always have the best news for people, and we know there has been controversial decisions since we have been operational, but we've tried to be as honest as we can about that with you so that you know what our thinking is. Showing respect for different views. There are often different views. People are very passionate about health services, quite rightly so, and very much collaborating with others in order to improve the care of the population. And that's really important. And the challenges that we have currently in the system, which you'll know about, which face the whole of the public sector, no one organisation can tackle those on their own. So it's really important that we all work together, particularly at the moment. So very much based on the clinical relationships, that's how the, if you like, the boundaries of the CCG were determined. And it's good that we're pretty much coterminous with the district council as well. That gives a degree of joined up discussions and thinking across the district. So we work very, very efficiently. We're quite small in terms of how many people work in the CCG. But what we do is partner with others and bring in associates and other partners where we need additional expertise. But the whole premise of CCGs is that they are quite small and agile organisations able to make decisions and move services forward. I mentioned some of the local challenges. We know that there is a considerable financial challenge facing the whole of the public sector at the moment. And we have had some local quality challenges that we have worked with partners to try and improve. We know that there was a KEO review at our local acute trust and a CQC hospital inspection which revealed some local challenges again or kind of highlighted those. Mortality rates have significantly improved actually over the last couple of years, and that's been a lot of hard work on the part of all people involved. But there are sort of significant pressures in the NHS, as people will be aware, particularly around accident and emergency performance, referral to treatment times, waiting times, and we do unfortunately have errors that go wrong or incidents that happen. And part of the CCG's role is to make sure that the system is working together to address those issues as well as we can, and that when incidents do happen, that we learn the lessons from those. So given that level of challenge, we have been very proactive as commissioners, and we've worked across the whole of Mid-Nots so that we get the best population coverage for the task in hand, to strategically think about how we are going to address the NHS challenges and leave a legacy of really sustainable and excellent services over the next 5 to 10 years. So we do have a kind of 5-year plan, which you'll see over on the Better Together stand. You'll see how that's going to look locally. And within that, that includes all of the health services for Newark and Sherwood. So that includes Newark Hospital as a vital part of the health system. It also includes the community services as well, and general practice in particular. So it is a very joined up way, and it's very much working with social care as well. So it's a very different way of looking at health services. It's not looking at different parts in isolation, it's looking at how they will all work together. So in a nutshell, there is much more emphasis on developing community services, supporting people at home in a more joined up way. When people do need to be referred to hospital for planned operations, making sure that that's done in a very sort of the same quality of referral will happen across the patch, and whichever GP practice you go to, you're just as likely or not as likely to be referred to the hospital should you need it. So it's making sure that referrals to hospital are based on clinical need in a very, very robust and standardised way. And then also, for urgent care, we know that the system is confusing for people at the moment. We've got 111, out-of-hours GPs, the minor injuries unit, A&E, GP in-hours services, which do provide urgent care. So there is such a lot, and it's difficult. We're trying to join those together more so that it's easier for people to access that and to understand which bit of the system is there for them at that moment in time. So our plans are very much based on how people have said to us they think services currently work and what needs to change going forward. And we have done a huge amount of engagement with people in a variety of different ways. But the key things that came out from what people said to us loud and clear was, at the moment, services aren't joined up enough. People who need visits to their home can often have several professionals coming along on the same day doing broadly similar but slightly different things. Lots of different assessments taking place. They have to keep repeating themselves. And it's not good care. It's very it imposes on people's day-to-day lives in that they're having to work around appointments a lot, but also it's not the best use of the resources that we have and that are very precious resources in the NHS. Wanting to be at home if possible, not to go into hospital if it can possibly be avoided. Some concerns about the funding, which, you know, do reflect the current times that we're in. GP access as well, that was highlighted quite considerably, and we are doing some work around that currently. And then the need for better communication, partly with the people who are having the care and their carers and families, but also between professionals and between different parts of health services and social services. And so the Better Together programme is very much about how we join those up and make them work better for people, based around individuals' needs rather than around the individual needs of lots of different organisations. So lots of, as I say, talking to people, understanding what people think about the services. Okay, so one example that we're currently working on of things that people said to us is people said actually discharge arrangements are quite complicated. It takes ages. You might be ready to go home in the morning, but actually things don't get sorted out until later on in the afternoon. Or it might be that people are in hospital waiting for packages of care to be organised outside of hospital. So one of our priorities this year has been to, if you like, streamline the discharge process, and we have re-specified with our providers how we want that to work, but there's lots of work also going on with the clinical teams to try and see how they can work together much more effectively to make the whole discharge process better. We know that that isn't fully resolved yet, but that's a big priority for us that we're working on. So we are on a journey from having lots of separate services, paid for separately, some overlap between services, and we're on a kind of a journey, and there's lots of things that we have to line up as commissioners to make those changes happen. So just to think about that roadmap and that journey in more individual parts, where we are now is that we've done a lot of work to look at how all the money is spent across Newark and Sherwood, across healthcare and some social care as well. And we know that if we carry on delivering services as we currently do, with the growing demand in the population across the whole of mid-Nottinghamshire, the current deficit that's in the system at the moment, which is about 25 million or so pounds, which is largely associated with the acute trust sort of bottom line at the moment, will grow to 70 million pounds in 5 years if we carry on doing exactly the same as we are now. And clearly we can't allow that to happen, because that's when very short-term decisions get made. So we're being very proactive to, if you like, get on top of that before the problems get out of hand. We're also very mindful of the quality of services, and as I say, there's been CQC inspection of the hospital, and that regime is now coming into general practice. So our local general practices over the next certainly couple of years will all have CQC inspections in the way that the hospitals have been inspected. So that will be quite a new thing across the whole country, but it brings general practice into the inspection regime. So having decided what the vision for the services is, which is much more joined up care outside of hospital, we're now into implementing that and making that happen. And a big part of that is how the commissioners and the providers all work together to, if you like, think of new, better ways of doing things in a more joined up and effective way. And clearly that has to have, you know, sort of patient and public involvement as we go along to help influence and design how things will work. So as well as thinking about how the clinical services work, we can't make the changes stick and happen without some other enabling things along the way. So we're working very closely with the regulators, NHS England, who, if you like, regulate the CCGs, and Monitor, who regulate the hospitals and the providers. So working with them to think, how can we make sure that we get really good quality within the resources available to us. The green lorry is the estate strategy. We are looking at how the buildings are used. There are lots of buildings across Newark and Sherwood and Mansfield and Ashfield, and we're looking at how they're all used. One of the sort of, if you like, most notable local ones is Newark Hospital, and how well that is utilised. And clearly part of our plans need to be to make sure that it's fully utilised. We have a primary care strategy, which is thinking about how, if we're having more care closer to home, we have to make sure that general practice in particular has enough capacity and capability and is working with the rest of the system. And then we also, on the red lorry, have a commissioning strategy, and we're moving away from having lots of separate contracts with lots of providers. We have contracts with about 70 providers at the moment, to joining that up and having a main contract that really brings lots of providers together to deliver that care in a way so they're incentivised to work together rather than compete with each other or work separately. And so we think that certainly within 2 years we will have services locally that are social services are working integrally with the NHS in a much more way, and the local community teams in the PRISM scheme that some of you may have heard of is really a very good example of how that will work. Okay, move on.
Thank you very much for that, Amanda. I think that was a good summary of sort of where we are at the moment, but also looking at our ambitions over the next 5 or so years. I hope you picked up from that we do have quite ambitious plans for healthcare within Newark and Sherwood over the next 5 years or so. And there's actually lots going on to try and make sure that we get to our final end point, which is providing an excellent high-quality service to our public and patients, at the same time making sure that it's a high-quality service that we're all proud of. However, I think it's very important that we pause and just look at achievements so far and how we've helped to improve the NHS and the patient experience across Newark and Sherwood. There clearly are sort of ambitious plans for the future, but that doesn't mean that we can't take our eye off what's happening today. There was a good analogy made a few weeks ago I heard that I like, which is almost it's trying to change the tyre on a car whilst hurtling down the motorway at 70 miles an hour. You know, and it's no mean feat to try and make sure that we're providing high quality service at the moment whilst actually trying to put resource into making sure that delivery goes on into the future. So I just want to spend the next sort of few minutes there just talking about some key achievements over this past year or so and where we are, just to try and highlight that we are still keeping our eye on sort of delivery for now as well. Amanda touched on the mortality ratios at the beginning of her talk, and as I'm sure no doubt people are aware, Sherwood Forest hospitals were part of the care review because actually they had higher than expected mortality ratios. And we've been working very, very hard with them to have a look at reasons for that. And some of those actually are reasons that sit within the hospital, but actually some of them also are reasons that sit within the community and primary care as well. So it's a shared thing that we need to do to look at those together. Not wanting to bore people with the statistics, etc., but standardised mortality ratios are almost a benchmark of where we are within the country in terms of sort of mortality so that we compare ourselves to other areas. Figure about 100 works out at about the average mortality. So anything above 100 is higher than the sort of the average mortality for the country, and anything below 100 is lower than that. And as you can see, the East Midlands average there is just slightly above sort of the average at 100. Nottinghamshire itself was a little bit higher than that. Newark and Sherwood, back in 2011, were certainly sort of sitting there above the national average there. The next year we saw a little bit of a sort of spike up there, but I think it's really encouraging that in 2013 we've actually seen that standardised mortality ratio drop to way below the national average there. So I think that's testament to a lot of the hard work that's been done across the healthcare system, not just the CCG, but also the providers such as the hospital, our community providers, our mental health trust as well. You know, we can't take credit for all of that work because a lot of this is preventative as well, and that's hard work that's happened prior to this time. But I'd very much like to make sure that the CCG continues on that ilk and we remain below that national average there, something that we should all be very much proud of. I think again, Amanda touched on the fact that CCGs are small organisations, they're lean organisations, and they're there to function effectively for their population. There's been considerable transformation across the NHS, and that's meant reducing a lot of the bureaucracy and also reducing personnel across the NHS as well. We were really, really proud that last year we were shortlisted as one of the finalists for the HSJ, that's the Health Service Journal CCG of the Year. The Health Service Journal is a weekly publication, which is the authoritative publication from the media and the press that goes out to all interested parties in the clinical setting of NHS and other providers. So to actually be shortlisted as one of the finalists out of 230 or so CCGs was absolutely no mean feat for us. We didn't win it, unfortunately, but we did get to the final 4 or 5, and so we're very, very proud that our team actually worked really hard to demonstrate to the judges at the HSJ that we were providing efficient, high-quality services to our population within a very, very lean system. And actually, we just learnt a couple of weeks ago, actually, that we made the top 100, again, of the Health Service Journal's best places to work within the NHS. That's not just CCGs, that's across the whole of the NHS. So that's all of the hospitals, all of the primary care providers, all of the community providers as well. So I think that's true testament to the fact that our staff do feel very valued. We absolutely believe that the staff that work for us, do an absolutely key job and have a key role in terms of outwardly facing and sort of helping our population, but working very, very efficiently. They often do this under really, really tough circumstances. We are in a time of austerity. Resources are very stretched, but I would absolutely sort of commend the staff for giving, 110% at all time. And I think another one of the important things there is that a lot of our officers and the people that work within the CCG have been clinicians as well. Amanda, Elaine, Robert, Simon at the back, to name but a few, have all had a clinical background to start with, so they understand clinical issues and they can take those issues and the understanding forward in terms of the planning for the future that they do within the organisation. I'm sure most of you have heard of our PRISM project, which is a way of profiling patients' risk of admission to hospital, integrating their care and also promoting self-management. This has now been up and running in Newark and Sherwood for sort of a couple of years or so now, and across Newark and Sherwood, every practice and every patient is covered by one of our sort of PRISM teams. The key to this is actually that integrated care that's delivered to patients, and you've probably heard over the past few weeks as we get into the party political sort of annual conferences about NHS being a big subject to talk about, and how integrated care is absolutely the way that we need to be going within the country, integrating with other providers, but also with social care to meet the needs of people going forward. We're absolutely committed to that. We're actually ahead of the curve on this one. We picked up this was a really important a service to take forward into the future. So we're very much sort of, on the national map in terms of, sort of having this and being a leader in it there. And indeed other areas are coming to talk to us about how we've done it and how we can sort of continue rolling things out. We're now starting to actually sort of develop the PRISM Plus model, which is rolling out that care to 7 days a week as well. People become unwell at the weekends, but we need to make sure that they have that same level of service at weekends as they do during the week as well. So that's the next step that we're actively working on at the moment. We estimate that just under 700 people so far have actually been cared for in their home homes, where if there weren't the PRISM team around, they would have had to be admitted to hospital. And another part of the PRISM work is actually taking people out of hospital sooner than they would do otherwise as well. So people that are fit for discharge but need additional aids or assessments doing, but can be done at home. We're trying to make sure those people are being discharged as soon as possible so they are back in their own familiar surroundings where all that care can be given as well. We're also starting to provide outpatients care closer to home as well. Really important that, patients don't necessarily need to go to hospital sometimes for outpatient clinics. So we're developing community clinics with consultants from the local hospitals, but they're being run in a number of different satellite areas across Newark and Sherwood. So Rainworth, Billsthorpe, Balderton, to name but a few there. So if you don't really need to go to a hospital for a particular appointment, then that can be done in a more local sort of environment to yourself. And 3 of those services there are dermatology, gynecology and pain management we've got up and running within those community services. The hospital, we've been through sort of a lot of significant transformation with the hospital over the past few years or so. We produced a vision and strategy document last October, which was in conjunction with public, patients, also the providers and the CCG, just to look at how we could absolutely make sure that Newark was a sustainable hospital for the future. There's been a lot of press and discussion about, you know, using it or losing it, and also that we're running it down. I think if you just have a look at some of these figures here, you know, the amount of patients served between 2012 and 2013, that's gone up. Looking at sort of the throughput in terms of how many of those, you know, contacts made in different departments, these are quite significant numbers there, absolutely huge. You know, and I think that's testament to the fact that we're not running the services down, and we're absolutely committed to make sure that we put the best quality services into Newark as much as we can and deliver those very safe services. You know, 52,000 and 53,000 outpatient attendances. You know, that's a huge amount. We want to see that increase, and we want to see that increase with real efficiency as well, so people are having almost one-stop shop, so they can have their diagnostics and investigations done at the same time as they're having their appointments. They're not having to go forwards and backwards, so they can get very quick care in a very timely way. As I say, we're absolutely committed to that sort of sustainable future for Newark Hospital. We want to absolutely make sure that we continue with services there, but we also build on services and put more services on there. But the paramount is the fact that we need to make sure that we have safe and high quality services there as well. So we absolutely are committed to that, and we must make sure that that quality does continue to improve, and we'll be keeping a very, very close eye on that. I've discussed the fact that we want to try and make sure that people get the right diagnostics the first time as well, so they're not having to go backward and forward to the hospital. And Rob will come on to later on about talking about the MIU unit and urgent care and how we look to sort of model that in the future as well. So we're now going to play a short film just to talk a little bit about our achievements.
The CCG is accountable for understanding the health needs of the population and making sure that we plan services that will meet those needs, and then we have to make sure we buy those right services on behalf of our population and then monitor those services to make sure that they actually are achieving the NHS standards that we expect. Engagement is so important because to bring about real change and the best possible services, it involves everybody in the system. It involves understanding what patients and their carers want, understanding how the staff feel they can best deliver that, and then making sure we've got the best international evidence and that we're working from that as well.
I think the CCG is there for multiple reasons. I think it's there certainly for the patients, but it's also there for the workforce, the clinicians that are around.
I expect them to listen to us as professionals and to listen to our opinion about what's best for the patients and our care, because we're the people who are face to face with these people.
So it's important that they have quite a solid plan, understand what the health needs are of that population, and then commission services that provide the care that those patients require.
I think that year prior to reauthorisation was a potentially steep learning curve for us. I think we learnt a lot about ourselves and about the organisation we either were or wanted to be. The past year, I think, has been an even greater learning curve. We've started to do a lot more. I think we've started to be more serious and have greater vision, but with that becomes greater responsibility.
The really excellent clinical leadership in Newark and Sherwood, along with managers working alongside the clinicians to bring about service change, has been recognised nationally, and we have made radical changes to the way that the community services work and also to rehabilitation models in Newark and Sherwood, so we have some cutting edge services for our population.
The CCG is here to ensure that the population of Newark and Sherwood receive the best possible high quality health care. We've been working really hard to try and make sure that local schemes and local initiatives are taken forward so that we provide the best possible care for our patients. This includes preventative health care, public health services, but also the whole wealth of services from cradle through to grave, so making sure that pregnant women and children are looked after well, all the way through to more frail and elderly patients with long-term conditions, and also ensuring that people receive a good quality of care towards the end of life.
I think our role as a CCG is to help support clinicians and, in the best interest of the patients, make sure that what we're delivering is best quality.
We have a really good working relationship with the CCG, and I feel that as healthcare providers we do have a voice in the CCG.
But I know that if I need help or advice from anybody, whether it's a GP or a community matron, specialist nurse, then I know that I can get it.
We meet regularly, we're in regular communication, and it's got a supportive atmosphere to the team in what's quite difficult and challenging work, really.
With working with the CCG, it's enabled me to get to know a lot of the hospital consultants a lot better. It's enabled me to get to know a lot of the community-based teams a lot better. And now, knowing these hospital consultants, I can provide better care for my patients. I'm able to pick up the phone, I'm able to get patients sorted closer to home, quicker, and they have a far better service without travelling for it.
I think the things that inspires me is that the CCG at the moment are talking to lots of different people. They're talking to health professionals like myself, and we're getting involved and we're getting given the opportunity to redesign services.
The CCG are responding to what we feed back and what the patients need, what the deficits are within the services, and actually thinking more innovatively about what we can do in the future to actually take things one step further.
I think they're thinking outside of the box and then looking at new ways to try and approach the demands within the health service.
I think they are a really high-performing clinical commissioning group. They have really good engagement with their GPs, who are the commissioners. They have done some really good work with their providers, the hospitals, Newark, Sherwood Forest, and also the Healthcare Trust. So they work collectively with multidisciplinary teams, which is really good for the population. So it's not just a medical model, it's a social care model as well.
What inspires me about the way that the CCG is planning healthcare is that I think we've got a real radical vision about taking care out of hospital and providing it where people live in their own communities.
I think we've got a very dynamic CCG here in Newark Sherwood, and I think that we're very lucky.
We've had a challenging time over the last few years with changing things, particularly in Newark, and we've learnt a lot from previous attempts at engagement. So I think we've learnt from it and we're now moving forward, and it's actually a really good place to work, and they're very supportive, and I think with the general public involved as well, it can only get better.
I think it's quite exciting actually that your CCG is doing stuff that's quite pioneering and is recognised nationally, and actually when you hear about other CCGs doing a similar sort of thing maybe 2 or 3 years down the line, it makes you think, well actually, you know, we came up with some good ideas to start with, so must be doing something right.
By far the best bit is when you can actually have a genuine conversation with a patient who's been really moved, touched, helped by our services. That's the bit where it kind of feels worth it.
A lot of the people that come in here are obviously elderly, and a lot of them live by themselves. These people here, they somehow seem to be able to get them out of their shell.
It seemed to be a family unit. You know, you had to come out of hospital and come back home to the family.
I'm very pleased with them, you know, they've done marvellous.
They seem to have more time to listen to you. The kindness and the way that they handled themselves, well, they couldn't do enough for you.
I knew I could leave David and not be worried about that he wasn't being cared for properly, and because he was more confident in moving around and doing things, then it took the burden off me. It eased the situation up for me. So yes, I did benefit and still have benefited an awful lot from it.
It's definitely a step forward. I was ill a few years ago and there was nothing like this. You felt very much on your own. The 2 or 3 nurses I've seen have been, and the actual staff have been very courteous, very helpful, very informative when I wanted to know things. I didn't even know it was there, and I've worked in Newark all my life, but I'm very appreciative that it is there. And they are an excellent group of people, there's no doubt about that.
The NHS is something that we should be proud of. We accept the fact that it may not be perfect, but it's one of the best health services out in the world today. It's still one of the things that people hold true as one of the great things about this country or about the area in which we live. My role in the CCG allows me to be an integral part of that change, that development and that progression. It's certainly a challenge, but actually each day I know that I come in, I'm trying to do my best for my patients, whether they are face to face with me or whether they're just out there within our population that we serve.
What makes me proud to be part of the NHS is that I can make a real difference. I have a fantastic role in terms of seeing patients on a day-to-day basis, being able to treat them, being able to communicate with them, being able to track their lives through and actually see the real difference that we can make. But also I have this absolutely golden opportunity in terms of being the clinical leader of the CCG to really make lasting changes for the future.
I think there's always something that we can improve on. I think we recognise that whilst we have an excellent basis for a service, that there is so much more potential. We hear and discuss about potential inefficiencies within the system, whether it be within pathways, whether it be within general meetings, whether it be within the way we actually provide the care. And I think this is what inspires us to carry on working to try and better ourselves each day. I think we should be proud of what we do, but I think we can be even more proud of what we can do.
The night that we had that terrific flash flood, the staff couldn't go home, the visitors couldn't go home, and we all sat in the dining room laughing, listening to the thunder and the rain and knowing that we were all stuck there.
Last week I went home and I walked from the car to the door and inside and walked upstairs.
And she came up to me one day and says, "Seen that, David?" Well, I can't see it really out of the packet. I said, "But it looks like a sander." "Yeah, that's right." Of course, out came in the box and he says, "I don't know how it works." I'm doing away, and I'd sanded this bench down. Now suddenly a penny dropped. I says, "You crafty devil." And she just looked at it and she's got a biggest smile and walked away.
Thank you very much. You've done far more than what I could expect you to do, and nobody could be more appreciative of what they've done.
Thank you. I'm now going to hand over to Simon Crowther, who's our Chief Financial Officer, who will give us a rundown and summary of the 2013-14 financial accounts.
Thanks, Mark. Morning. I'm going to talk to you about the money, and I'll try and keep this as simple as I can. I want to talk to you about how we performed in 2013-14, but I also want to spend a bit of time looking forward as well to the financial challenges that we face as the CCG. So when CCGs first came into being, NHS England decided to set CCGs, rightly so, some financial performance targets. So there are certain rules that we have to remain within as a CCG, and that govern how well we're deemed financially. So just spending a couple of minutes on those and explaining them. First one is a really important one for our CCG, and this is about how we spend the money that we get. Amanda mentioned earlier, just over 150 million. How well do we spend that? How well do we utilise it? And actually, how well do we make sure it gets to frontline services for our population and our patients? Meeting the planned surplus target. So again, this is nationally set. All CCGs should plan to make a 1% surplus. And this is around good financial management, really, and making sure that what we don't do is run resources too close to the bone. Remaining with the running cost allowance. And again, Amanda mentioned earlier how there's been a lot of focus on making sure health service money goes to the right place, goes to the patients, and we're not spending too much on the administration and the management functions behind it. Remaining within our cash drawdown, that's basically looking at cash in the bank and making sure, good practice, as an NHS body, we don't go overdrawn. And paying suppliers within 30 days. Now, this is NHS suppliers and this is non-NHS suppliers. So this is around Are we effective as a business, and are we looking after particularly some of the smaller suppliers in the local community by paying promptly? You can see from all those that the CCG had a very successful year, and we met all our targets that were given to us, some externally and some we set internally as well. And we had a good year, good focus, and achieved everything we wanted to. So I mentioned the importance of getting money to the front line for our patients and our population. What this slide shows is, where did we spend that? Where did the money go last year? You can see there the vast majority, well, over half of it went on acute services. Services such as Sherwood Forest Foundation Trust, but also acute providers over in Lincolnshire as well. We then spent quite a lot of our money still on mental health services, community services, right through to ambulance services. And at the bottom there's some information around who are our main providers, who are our main healthcare providers, and where does the majority of our money go. The challenge for us moving forward is, as we all know, money is getting tighter and tighter all over the country, not just in public services. And the challenge is how we maintain that, keep the quality high, but still deliver some of the strategy that Amanda talked about earlier. So, just looking ahead, again, some of this has been covered, but the financial challenge ahead. We all know finances are tight. We all know that things are going to get more and more difficult to achieve things that we need to financially while keeping quality as it should be. So we know there's going to be a shortfall in funding going forward within the health and social care system. So there's a real challenge around how we tackle that. Amanda already mentioned earlier that we believe that's likely to be around 70 million for the mid-Nottinghamshire health community in 5 years. So that's our framework, that's our real challenge of what we need to deliver within. We know the population's getting older and it's requiring more complex care as well. We know there's different expectations of healthcare, and you could say there's higher expectations of healthcare as well. And the population's needing a different sort of healthcare. We know it's changing, and we know we need to redesign to meet that need. But most importantly, the bottom point there, we need to do all that while keeping quality as it is now and actually improving it where we need to as well. Quality is not a negotiable, really. That's got to be the main focus of everything we do. This last slide just sets out some of the context, some of the financial context of those challenges for our CCG moving forward. So you can see there, if we concentrate on 2014-15, which is the year we're in now, we received a central allocation, so new money effectively from the centre of just over £3 million. And our job straight away is to say, how can we spend that most effectively? Again, how can we get this to frontline services and do what we need to do for our patients and population? But what we do know, as we mentioned earlier, there's going to be a growth in demand. And that is going to cost money, and that we absolutely need to fund. We estimate that to be this year, that's going to cost us around £3 million again, just over. So you can see straight away the challenge we've got is new money comes in, and already with the growth in our population and the demand for services, that's gone. So straight away we've got a challenge for how we think innovatively, how we think differently to do the other things we need to do for the population. We know we want to invest in services for our CCG. The Better Together programme that was talked about earlier, this year we're aiming to invest, again, just short of £3 million in doing services in different ways, bringing services closer to home. There might be new services, there might be new drugs. Which leaves us at the bottom there, our challenge for this year. And this is where we have to do things differently, we have to think differently, we have to say, how are we going to save the money to make all those things above it all affordable, so we still keep with the same financial performance that we saw on the first slide. What we've got in the second column there as well, that just gives you a bit of how does it look going forward for the next 5 years. Obviously the numbers are bigger, but the challenge is the same. The challenge is all about how do we keep quality where we want it to be, how do we get the right services for our patients, but how do we ultimately make this affordable in the financial climate that we're in. Okay, thank you for that. Not going to spend too much longer on the money now. Hopefully you've got really a key feeling of the challenges for us going forward and how we performed last year. So I will now hand over to Elaine Moss, who's our chief nurse, and we'll talk to you some more about quality.
Good morning, everyone. Mark and Amanda and the film has talked to you, given you examples of some of the improvements that have been made in the first year. I'd now like to talk to you a bit about how we get feedback from those of us who use our local health services and those of us who are carers of people who use our local services. And firstly, I'd like to start by saying thank you, because actually I recognise a number of people in the audience who've provided us feedback in this first year, and it's extremely valuable at adding to our knowledge around how services are being provided and what it feels like to be a recipient of those services, to help us look at how we prioritise to make changes going forward. So my plea is please continue to do that in this coming year. It's extremely important whether you feed back to us about how a service provided good care, as much as if there are things that you've identified that need to be improved, because as many lessons can be learnt from the way things went well as how they need to be improved going forward. As I'm sure many of you will know, there are lots of ways in which all organisations gain feedback to help improve services. One of them is a national way of collecting some very high-level intelligence around services, and that's called the Friends and Family Test. And I suspect if you have either been in hospital or have had people, relatives who've been in hospital, you may have sort of known about this question that's actually asked on a percentage of people that are discharged from services. And actually some of you also will find on your own GP websites a question that's very similar. It's important to actually make sure that sort of you use that opportunity. And during last year, we got some very valuable data that enabled us to start looking at provision of services in specific areas across our local trusts. You will also find that sort of there are a number of other ways in which you can feed back to us. We have a patient advice and liaison service that is run by CVS for us, and you'll see there's a stand over there. Again, it's important to sort of use that if you've got any questions or concerns, but also we do use whatever comes out of that to give us intelligence on trends and themes. As with all organisations, last year we had a complaints process, and we used that to tell us around sort of services that we needed to look at in our local providers. There are a number of other ways that last year were extremely important to us. One was our stakeholder reference group, and also a number of our local residents sit on some of the improvement groups that, again, Amanda and Mark have already talked about around Better Together, and some of those sort of forward planning areas. Without doubt, we know that during this last year, we have identified and Care Quality Commission and Monitor have identified a number of areas in which our local providers need to continue to work to improve services. And as Amanda mentioned before, a number of organisations locally were subject to the KEO reviews. We were very heavily involved in providing intelligence and information for these during the year, And the feedback that you gave us through the systems that I mentioned on the previous slide helped us sort of feed into that process to sort of focus where the inspection took place. As again, you will probably know that following that, the two trusts that are mentioned up here were placed in special measures. And what that means is that the organisations were given additional support to help them improve services. And that included things like having additional support from the CCG, but also from Monitor with an improvement director. It's crucial that we make sure that we have systems in place that enable people to have a number of different ways to provide feedback, because although we have visits to our local providers on a regular basis, and we have the visits that come from the Care Quality Commission, what we know is that things can improve and sometimes not be as good, turn over very quickly. So we've implemented during the year something else we've called patient stories, where we take the feedback that you give us and work through what was the key concerns, what that actually felt like from the patient's point of view, and actually what the patient wants to see differently. And we now start our governing bodies with one of those stories and a number of our subcommittees to help us focus on what's really important, but also, as I say, what it actually feels like to use those services. And again, I would like to use this opportunity to say this is extremely valuable information to us. And again, whether that's good experience or areas for improvement, and we would like to hear more and more of those stories going forward. Finally, all of the sort of pieces of information that sort of we pull together, we put it alongside lots of other areas of intelligence that we gain. We do go out and visit areas both in care homes and also acute trusts. And where possible, we try and sort of ask either someone, a layperson from one of our groups to come along with us to help us have that sort of additional sort of view of sort of services. And then what we make sure we do is feed back to that organisation and ensure that where there is a need to improve, that feedback results in an action for us to monitor going forward. We also make sure that this intelligence feeds into some of the groups that you saw on the film there was looking at sort of reviewing and redesigning services going forward. And that intelligence also gets fed into that. I'd like to take this sort of opportunity to say to you that, as my colleagues have all said, the quality of the services is so important to us. And although, as Mark said, many of us come with a clinical background, that gives us that professional view, but it doesn't give us that view of what it's like to actually be in the service. So we couldn't do this without you. So, as I say, please make sure you use all of your opportunities to be able to feed back to us around how we can start to look at sort of improving going forward. I'm now going to hand over to Robert, who's going to talk to you about future developments.
Thank you very much, Elaine. I'm Robert Ferris-Rogers. I'm Director of Engagement and Service Redesign at the CCG. And I'm going to give you a flavour of some of the things that we're actually doing at the moment to improve the services in Newark and Sherwood. As Amanda and Mark have set out and others, all of what we're doing at the moment is framed within the Better Together programme. So we have our 5-year vision about healthcare. We're not going to do that all in one big bang. We're doing that over a period of time. And some of the things that I'm going to talk to you about today are things that we've started to do. So the first thing that I'd like to just got the technology working now. The first thing I want to talk to you about is our strategy for primary care. You'll find that in your bag that you got given as you came in, a summary document of it. And we developed this very much with our member practices, but also our stakeholders in our local community. And colleagues, particularly in the CVS, were absolutely integral around working with our local communities about understanding what was important to people around primary care. And those views from both our member practices and our broader stakeholders were absolutely integral to actually be built into that. What people identified was that we wanted to see improved outcomes for patients, and some of the things that we're doing this year is about, you'll see changes when you go into your GP practice over the next 6 months around GPs using a system called Mapper Medicine to actually ensure that the care that they are giving you is based in the best evidence and guidelines that are available to us currently, both nationally and internationally. And Dr. Nigel Marshall, who you've seen on the videos, has been absolutely instrumental in practices in rolling that out. We also, as part of our primary care strategy, saw a need to improve experience and understanding of what patients want. So over the next year, we will be doing a patient access survey for our entire population to really understand the sorts of services that local people want in terms of access. And our GP practices also are coming together about working around services such as the PRISM care that Mark's talked about earlier. One of the major things that GPs spend a lot of time doing is prescribing medications, as well as all of the broader stuff. And we're working in practices around ensuring that the prescribing is as of high quality as possible. And all of this needs to be done within an affordable framework. So I do recommend you read the strategy and kind of get involved, whether that's in how you actually interact with your GP practice or whether you want to be involved in actually us taking that forward. This year, we were successful in bidding for some monies as part of the Prime Minister's Challenge Fund. The Prime Minister's Challenge Fund was very much about improving access and urgent care in primary care. As part of the work that we'd done around Newark strategy and also the Better Together programme, we had a very strong view about and vision about how we wanted to see Newark Hospital as a hub for urgent care and primary and urgent access to services in GP practices. We've been developing that and designing that with our member practices and a wide range of providers in the system. And we've got a number of areas that we're going to test over the coming 6 months, including better triage, new services, and using existing services in a different way, such as the emergency care practitioner in our local community. One of the big areas that Mark talked about briefly was the expansion of the PRISM service this year. So our PRISM service is going to be extended and is already being extended. So the hours that the PRISM service will work will be extended to 11 o'clock at night and also working at weekends, with the hope that that will keep more care close to people's homes and in people's homes wherever possible. Alongside that, we're also taking forward the PRISM model into services such as cancer. So we have an ongoing relationship with Macmillan about actually how do we really deal with cancer in the same way as any other long-term condition. There's the survivorship of people who get cancer improves. And another thing that we're doing this year is about actually further developing the PRISM ward. You saw people playing the Connect 4 game on the video, and what an amazing service it is. You only have to spend time in there to see the energy and commitment and passion of the staff there. So we're trying to work with the unit about ensuring that we get that service as effective and efficient and patient-focused as we possibly can do. Elaine touched briefly about carers being as important as patient, and we've been doing some work this year around caring for carers. So we've worked again with our colleagues in the CVS about really building the partnership board that we have in place for carers. We've done some work which has made NHS funded carers breaks easier. And we're now working with GP practices to help identify carers and the support that they need. So we've worked in 2 practices that's been very successful, and we're aiming to offer that work out across the whole of Newark and Sherwood. And alongside that, we've just recently, with colleagues in the CVS, launched the website around dementiacarer.net, which has a really great opportunity to search and find local services for carers in Newark and Sherwood. And lastly, I'm going to talk about the work that we're doing around end-of-life care. We had a summit where we brought a lot of people together about end-of-life care at the beginning part of the year. That gave us some very clear messages about what local people want. And it brought all of those people together to actually agree what the priorities were for local end-of-life care. What came overwhelmingly was the need for better care planning in the last days and weeks of life, and Dr. Julie Barker and colleagues have been doing work with practices about ensuring that people, when they are at that very important time in their life, have the best possible care that's planned proactively. And also, one of the key things that came through was about the choice about where do people end their last days. And we're working with colleagues such as Beaumont Hospice, the expansion of our PRISM teams and other services to ensure that we can provide the care that people want in their own homes if that's the right place that they choose, or in a local venue, so that they can actually have the care that they need. We're going to move on now to a film about our future plans, so I hope you enjoy it.
I think that everybody should have the same quality of health if you've got £1 million or you've got £10 million or you've got £5. And if we can actually get more people talking about it, involved in it, we can actually have an A1 service that rivals any other service in the world, which I already think it probably does do.
What gives me determination is seeing the difference that it makes to people's lives.
Having that drive to make things better for the patients that we see is absolutely paramount.
The thing that gives me the most determination is seeing the changes to services and feeling that we can benefit the population, help people to live longer and healthier lives, and when they do need healthcare, to make sure it's the best that it can be and they are treated with dignity and respect throughout that process.
I've been a nurse for 31 years. I'm absolutely passionate about providing the best quality care that I can for the residents of Newark and Sherwood.
I like to go out to hard to reach groups. I like to help people to access and improve their lives and get the best out of their life.
I know as a young GP with not much experience, I used to get very frustrated. Why couldn't something be changed? Why couldn't something be done in a better way? Why do my patients have to wait, or there's a much better way of doing it? And the only way that you can get involved to make those changes happen is having that very active clinical engagement for the CCG.
I'm absolutely passionate about patient care. I'm a nurse at heart and always will be, and I think we owe it to our NHS to make it the best it can be and sustain that so it's the highest quality in the world. And I want things to be right for me when I'm an old lady, and I want things to be right for my family and the generations to follow.
And I know that without investment and support in preventing ill health, that long-term health outcomes will be profound, and putting that passion and commitment in the early intervention and support and prevention is going to have long-term value and benefit.
I think fundamentally at the centre of clinical commissioning groups is a very active stakeholder group, and we know that actually taking forward the mantra of no decision about me without me, we absolutely must make sure that our patients and our public are fully on board with us. We need to listen to their views, and we need to make sure that their views are taken into account, and also we're including the patients and the public in the decision making processes.
Our local population have told us that there is inconsistency in the services that are offered in their GP practices and in their own homes. We want to ensure that everybody has the access to the same quality services across Newark and Sherwood.
We have Gypsy and Traveller population, we have Eastern European population, we have lots of young mums in our population, people with disabilities and learning difficulties, and lots of older people obviously that will need services in the future.
One size doesn't fit all with healthcare, and we need to be very much focused on the locality and what's available locally, but also the personalities within our local community. This has been our first year as an autonomous and responsible organisation for healthcare within Newark and Sherwood. That's meant that we've been able to up the pace in terms of helping to plan our strategic direction over the next 5 years. We've been working very hard on the Better Together Mid-Not Transformation programme with our colleagues across at the Mansfield CCG, and we've been given lots more scope in order to improve quality and start to plan services for the future.
I think it's always important to be looking at best evidence and trying to test out new ideas so that we can grow all the time. So we work in a cycle of continuous improvement.
We provide face-to-face consultations both at Newark Hospital and a home visiting service as well.
We've been talking about how we can extend opening access to GPs, and we've been looking at various models that we can do this with, and we've had a number of patients in with us today telling us what's good and what's bad and how we can improve things for patients.
And moving forward, we'll be looking at assertively in-reaching patients from hospital and utilising the skills within the team to facilitate early discharge. We're just striving to push it forward just to help the community as much as we can.
I think the changes that I've seen over the last 7 years as a community matron, my role has evolved in that time and has continued to evolve, and I can see that we're making a real difference for people. Every day is different. Every role that we kind of introduce into the integrated care team brings with it some new experiences and adds to our breadth of knowledge, and just being able to achieve the best care for patients keeps me excited.
In terms of the way we discuss things, we start off often on a big scale and try and get as many voices and opinions as possible. So it helps to guide us and support us ourselves through that whole route. We then obviously need to take home and take on board all those elements, but also look at them in a context of where we are as a commissioning group and what our responsibilities are. I think within any element of healthcare redesign or service that we provide, the patient is the priority. It's vital that we include the patient in all aspects of discussion and service redesign.
It makes sense to communicate with your customers. I mean, let's face it, the patients are the GP's customers. So if you want to find out what it is they want, then you can deliver a better service to them.
Quite often patients are scared at saying something because they think it might affect their patient care. I would say no, definitely not. We can actually take it anonymously and pass it through to the relevant authority. That's not going to affect their care, and it's best if we know, because then we can change things for other patients. We want to know from patients what's actually happening out there, so we want to know their experience.
And if you want to know how a service really works, or even better, if you want to know what doesn't work about a service, you won't find it in a policy document, you'll find it in a conversation with service users.
Communication's the key. It's the key to quality and safety and patient care, and the only way you have that really is through face-to-face contacts. We can do as many bulletins and newsletters, but actually nothing beats being there on the front line, being visible, being accessible to people, to answer their questions, to observe their practice and to support them really where they need it.
If the local population and the communities don't believe in what's happening and don't own the plans and the strategies of the CCG, then it won't be delivered. Patients have really got to be engaged in their care so that they can do more for themselves where it's appropriate, and that they get fast and appropriate care in hospital when they require that.
But for me, what I'd like is the community to be involved, to have a voice, but also to be able to engage with people who are at low risk, recently been diagnosed with the condition, so we can give them that boost of morale and confidence at an earlier stage, which will be longer lasting.
So it's really important that they build from the bottom with patients and with the workforce their plans. That way they'll sustain what they're putting in place now.
I think it's important for the CCG to support networking between GP practices and other health professionals, because they basically then are helping the spread of information about what services are out there.
And there's nothing worse than organisations that work in silos. So good team working, cross-culture, cross-organisational communication is key, really.
We're at an interesting point in time in health and social care. Never has it been more important that we use the public purse wisely, but also it's important that we offer the best quality care for our patients. It's also important that we acknowledge that we all have a part to play, whether we be ground staff, clinical staff, meeting with patients, or the patients themselves.
Our responsibility is to plan services that meet the needs of the local people, and so therefore we have to understand what local people do think about services and what they would like to see in order to inform our plans and how we actually ask the providers to deliver the services.
We all access healthcare at some point in our lives, and actually being involved in planning it and developing it is our opportunity to make services right for us.
And we would really encourage people to go onto our website. They can put comments in through that. We have a PALS service again through the website, or a phone number. We would really encourage people to come to events. We have a rolling programme of public events, regular events that people can come to, and also they can email through to the CCG with any suggestions or comments.
Don't be afraid to talk to anybody within the health service who you engage with.
I think the most important thing is to get involved. If you notice that there's something that you think can be changed, let us know and we can look at changing it.
If you don't get involved, your voice won't be heard, and it is important that your voice is heard. So my message to you is get involved.
Thank you for that. We've now got about half an hour for questions and answers from people down on the floor there. So I think we've got some roving mics, have we? So what we'll do is I'll try and sort of pick people out and make sure everybody gets a turn, and then answer questions or direct it to one of the members of our team as best as we can do there. So do we have any hands for questions that people want to ask? Let's start. Can we sort of down at the front here, and then we'll... Chap at the front here in the check shirt.
Thank you very much. Thanks very much for your presentations, very interesting. One thing I'd like to ask is about access to GP services and choice. It seems to me at the moment, depending on where you live, you often only have the access to one GP surgery. And if you're not happy with the quality of care that you get in there, or the interaction between you and that GP surgery, it can be very frustrating as a service user. So are there any plans to widen the access, for choice of where you can go to see a GP?
I think I'll take that into two parts, actually. I think number one, we're absolutely committed to trying to make sure that primary care, general practice in Newark and Sherwood is of a very high standard, but actually that standard is across the board. So what we want to do is to try and flatten out the inequalities to make sure that wherever you live within Newark and Sherwood, you should expect a level of service from your local practice that is no different to another practice within Newark and Sherwood. And we're doing that, and we're starting to do that using the primary care strategy, looking at the quality. We've clearly got the CQC assessments on the horizon as well. And we're actually sort of employing staff to specifically work with practices to start to look at quality issues, access issues, etc., etc. So the first part there is I think we need to make sure that the offer to our patients is absolutely the same and high quality across the area. Number two, that there are on the horizon some plans being discussed by the Department of Health and NHS England in terms of patients being able to choose where they actually sort of receive their care. And that doesn't have to be within their own sort of registered sort of practice. I think that was initially born out of patients that maybe worked away or needed some continuity of care rather than just some emergency care as a temporary resident. But absolutely, this is about if you want to choose to receive your care somewhere else, how can we make the mechanisms work to do that? There is considerable sort of mud, as it were, to sort of march through to get there. There's information sharing in terms of getting the record right, so that actually wherever you choose to go, people know the past histories, what you've been, having in terms of medication, investigations, etc. There are, payment problems as well in terms of, well, how does a practice get reimbursed for that? At the moment, we get a set amount per patient per year, no matter how much that patient uses the service. So how do we get reimbursement for that service? How do we forward plan for it? Because clearly, if patients are coming in, you need more capacity, etc. as well. And there are discussions on at the moment, sort of through the Department of Health and NHS England, with CCGs in terms of looking at how that can be sort of taken forward. We've had some meetings locally about that in the last sort of few weeks or so. I understand that because I think of the information sharing and also the financial issues, things have been put slightly on hold about that, but it certainly is sitting there again, sort of to be looked at. Next question, we've got a hand up at the back, Simon. Was just anyone there? Yep, lady in the pink there.
Yeah, hi. You talked earlier about the funds that you spent. I'd just like to know how much was actually invested for Newark Hospital.
Okay. Simon, are you able to?
Thank you for that. The funds we invest for Newark Hospital is done through our local provider, Sherwood Forest Hospitals. I can't quote a figure actually off the top of my head. Happy to take your contact details and talk to you some more about that, but that's actually done through us, through commissioning services within our local provider. Now that'll be based, in terms of the slide you saw earlier in terms of activity, that'll be based on the number of activity going through. So when there's more activity going through the hospital, as we have seen in this year, the funds will have increased.
Yeah, I would like to know how much, an exact figure actually, and I'd also like to know how you're going to combat the evident growth that is taking place in Newark. You only have to go out in the town to see the massive growth in terms of new builds, and the main service that we want and need in the town is the hospital, a fully functioning hospital, and so. We're talking about the expenditure, we're talking about 14-15, so how are you going to combat that growth? What are you going to allocate to Newark?
Do you want me to? I mean, I don't think this is about combating growth. I mean, growth is happening, growth is inevitable across Newark and Sherwood, and we're absolutely and fully aware of that. We're not blind to it. We realise that actually as the population does grow, services do indeed need to change, and that's something that we're very intimately involved with our public health colleagues in terms of actually looking at what that population growth will mean to Newark and in terms of the health service provision. We also sort of are active stakeholders with District Council in terms of planning and looking at services and allocation of monies as well. So we do have an idea of how things are going to be changing in the future. I think the absolute message here is that we're not standing here with our eyes closed. We're not just going to suddenly in 10 years' time when maybe we've had a population growth of X% think, oh, core blimey, we've not got enough services here with it. Services are going to have to grow and change as the population grows.
But the demands aren't being met as it stands, and it's growing.
Demands are growing.
The demands, the needs, let's change the word, the needs of the community as it stands are not being met in terms of healthcare services. And so my concern is, every day I see the town growing and the services are not meeting the demands, the needs of the people that live here.
I think actually that's probably a very personal view in terms of demands not being met actually, because certainly all of the evidence we have in terms of provision of services, provision of outpatient, provision of urgent care, looking at the reduction in the standardised mortality ratios would actually suggest to us that on the population scale, demands are being met. Now, certainly on a personal level, there are certain people and groups that would feel that that is not the case. Absolutely, if there are any specific examples of that, as I think has been the theme that's run through the whole of the presentation, if we can have specific feedbacks on that, then we can take them forward and have a look at them. But I think when we look at actually all of the evidence in terms of healthcare across the whole population, we're very much aware of those growth and how it should sort of continue, but also try and make sure those demands are met.
Yeah, I just want to finish by saying when you said the specific needs, and if we knew about the specific needs, I went to a CQC meeting at the town hall, previously, and I was quite excited about it, I have to say, because I felt that as a group you would have a massive effect in a positive way. And I was there that night, and there was very, very specific needs expressed around the room, and I'm not sure that they're actually are being acted on.
Mm-hmm. Yeah, I think that CQC meeting you're referring to was there's a sort of pre-engagement visit when the hospital was sort of assessed recently for the CQC visit. Again, I think we do listen, we are there, we take all of the ideas back. Any of the public meetings that we do attend and listen to, we do try and feed everything back and have a look at how we can change things. But I think here it is, again, that balance of population versus people or groups. But any specifics, if there are still issues there, we would like to hear about them.
As Simon outlined, the money that goes to the acute hospital, which covers Kingsmill and Newark Hospital, we pay for the services, so we don't generally pay on a site basis, but there are some specific investments that we've said we definitely want to see at Newark, such as the Fernwood unit, which you saw on the film. And actually the development of that is a direct response to the growing elderly population locally. And we think that probably is an area for further growth as we go forward. So we're keeping an eye on whether that service can, if you like, deal with the level of demand. And that is growing in sort of popularity and use as people understand it more. And that is the type of service that is likely to grow locally. The other thing around dealing with population demand, all of the Better Together programme is about dealing with population demand. Services will look different, because if we carry on and deliver services as we did, it is not the right thing clinically, and it is not the right thing in terms of making the best use of our resource. If we get the right services in place that join up and cut out waste between how services operate, we can care for the additional people with the additional long-term conditions and diseases that we have. So everything we do is about meeting demand. That doesn't mean Newark Hospital will be an acute hospital. You know, I guess that's what you mean by fully functioning. It will have a broad range of services that deal with as much as possible locally within national standards and within the developments of specialised services locally. So what we can't do is have services at Newark Hospital which don't have the infrastructure to deal safely with certain types of serious illness. That wouldn't be the right thing for the
But they
population.
could have the infrastructure.
The hospital has never really had the infrastructure to deal with the most serious cases. It never has. It's just that as standards and scrutiny has got more, that has been more.
But the hospital has had infrastrucures for dealing with orthopaedic surgery, and successfully for a number of years.
It did, but when the KEO review took place, they actually said, we don't think you have got the infrastructure. We don't think
It actually stated in the KEO report that it was a danger to take patients further afield to Kingsmill and elsewhere. It actually stated that in the KEO report.
It did, and that was exactly the point. There isn't the emergency services at Newark. There never has been. If people had complications immediately after their operation, they had to be taken to Kingsmill, and that wasn't safe.
No, the KEO report actually stated that it was putting patients in danger, transporting them from Newark.
Yeah, that's right. That's exactly right, because of the lack of infrastructure at Newark.
Yeah. If you were to, the KEO report suggested and mentioned the fact that actually so far the services that had been provided there were absolutely fine. However, in the event of a major post-operative problem, which Newark has been very lucky at not having many, but if you were to have a major bleed or a very serious heart attack or stroke or something following surgery, which can happen, orthopaedic operations are major operations, the risk is actually the transfer out afterwards there, and that's absolutely what we don't want. So almost keeping our fingers crossed because it's never happened, I don't think is tenable. I don't think that's what our population wants in terms of just let's keep fingers crossed that you don't actually have a major complication. If you have a major complication, you want the experts, you want the equipment, you want the blood, you want the drugs on site to treat you so that you actually stand the best chance of coming out of that alive and with a reduced level of disability. Can we move on? Margaret? Thank you.
I recently had a letter from my GP surgery, which is yours, explaining that something to do with I was at risk of going into hospital and therefore would have a named GP. Is this general across the board, or is it just something from our practice?
No, this is national. Actually, this is national. There have been a few changes over the last year or so, and clearly the push, as we've discussed here, is all about trying to make sure that patients receive their care within the community, and where possible that we can avoid admissions. We know that a lot of people can be managed much better, you know, in their own environment in a community setting rather than going to a hospital. And this is absolutely the essence of our PRISM project in terms of trying to identify patients that potentially are at risk of an admission, trying to make sure they have the best possible care and they have a plan in case, you know, they do start to become unwell. Now, it's a bit complicated in terms of how that's actually looked at in terms of who are the at-risk patients, okay? So don't panic if you get a letter saying that you are at risk of a hospital admission, but there's lots of quite complex statistics behind looking at patients' ages, sexes, where they live, how many medications they're on, what sort of conditions they have, whether they've been to hospital in the past or not, whether they're attending outpatients, whether they have mental illness, whether they have alcohol problems, etc., etc. And they put all of this together and it gives us a risk for each practice. And out of that comes the sort of top 2% of the practice population that, with the modelling of these tools, suggests that these might be the people that are going to end up in hospital over the next year or so. So what we're doing with that is we're taking that patient population. That risk might change. Actually, a lot of this is patients that often have been in for 2 or 3 different things, but actually then they're absolutely fine and they move out and they're fine after it. So then they come off the list and new people will come on. But what we're trying to do within practice is make sure that that top 2% as it stands, and we regularly refresh it, have a plan in place. So we make sure that if we need to, we talk to them about sharing their records so that if the ambulance service are called, they end up in hospital, people can have a look at what's been happening with them in the past to try and get them out quickly. A lot of these patients are actually end-of-life patients as well. And again, picking up on what we were told there,
not one of them.
we know that a lot of them, not all of them, again, it's complex how they work these things out. I'm not saying you're dying of alcoholic, Margaret. So.
No, I've got complex medical.
Absolutely, and that's why that's been picked up. But this is about making sure that our end-of-life patients as well, or patients that sort of are approaching end-of-life.
Should I say
they,
I have no problem with the name GP either.
Yeah, and naming a GP and having a GP who's in charge of a care plan with you, and that often means that you'll be contacted face-to-face to discuss it. Often if the GP knows you well, they will do it without you because they know you anyway, and they sort of, see you quite often anyway there with it. But this is all about making sure that people receive the best care in the right place with adequate data sharing to make sure that they have a fantastic quality service. So it's a national thing. We're all doing it.
Thank you.
Okay. Have a question over here?
Hi, I'm Vicky Botton. I'm Vice Chair of East Notts Travellers Association here in Newark. I just wanted to pick up on 1 or 2 points without being sort of grumbling, but we've sadly got a big failure in the travelling community where you reach an end of life, and this has happened again in short weeks where I've been approached. Can you please help me or tell us where can we go to get help to get a portable toilet? We don't have toilets indoors, and if you're on a site, it can be a considerable walk. And with somebody with end of life, it's not always hygienic, if you wish, and that person can struggle, be it cancer and getting out of a door. Now, the only offerings that's ever been made is a commode. They would never have such a thing in the caravan. I'll say caravan as we know our homes as trailers. We would never dream, it doesn't matter how sick or how near to death's door you are, we wouldn't use that inside of our home, right? So it wouldn't fit in anyway. It's too wide. You talk about expenditure and dignity. I think a toilet would be about £19 a week, maybe a little bit more. To a pensioner, that's a lot of money. So if a person has got 2 or 3 weeks left, and I don't think travellers lean on the NHS heavily because they ignore their health because of the lifestyle, the lifestyle we live. Health gets ignored. And so I don't think we'll lean heavily. So the latest person to come to my door and say, can you point us in the direction of who can help to get us a toilet? What is, maybe say, £60 out of their millions to a person that's reaching the end of life, to give them dignity, to give that person dignity?
I think you're absolutely right. I think it's a very, very fair comment. I think, you know, one of the things we've spoken about here is how, you know...
Can I just say, I'm sorry to interrupt you, there still is a massive feeling of which doors to be knocked on. The only thing I could do, because I don't know about PRISM, is to go tell the people who's looking after to go to the social services at Newark Hospital and see if they can do anything. But nobody could.
Yeah.
The people have moved with the kindness of somebody else in a yard of someone's property where there is a toilet outside.
I think this is one of the problems in terms of when these difficulties or questions crop up. It is who is there to deal with it and whose responsibility is it.
Yeah.
And one of the big problems we have in health and social care is that
cross wires.
Everybody, or cross wires, or you know, we've never heard of that, so it's nothing to do with us. Try this person instead, etc. But the whole point behind what we're trying to do across this next 5 years is integrating all the services. I would certainly see something like that as being something that the PRISM teams could pick up in the future. So actually,
I think it's detrimental.
When we look at the sort of the advanced care planning, you know, for patients, then that is picked up. And so actually, we've in future we've got contacts, which mean that if that sort of thing is needed, then it can be sorted out. I don't think anybody's got any...
It happens times number, doctor. Yeah. Times number. This is happening.
I say I don't think we've got any qualms about getting it sorted. It's the sort of thing that absolutely we need to do. It's just about making sure that we've got the right process so that we know where to get it and who's responsible for picking up on it there anyway. So
but it'd be good if someone would contact East Notts Travellers Association.
Does Julie want to come in on?
Yeah, thank you. I'm the end-of-life lead for the CCG. I would really love to link in with the traveller community because we're desperate for more patient and carer engagement with the group to hear about needs and examples just such as you've raised. So if you want to come to me afterwards and give me some contact details, I'd be really grateful for that.
Yeah. And can I also say, like, there is plans set out via another organisation, and I think the challenges that they've been given are challenging in themselves, really. They've been, you know, they've been asked to do things that's impossible, i.e. mental health and things like that. You know, this is a very private community who's not openly going to talk about mental health. I have mentored many, you know, because I've been a trusted body. So there's a lot of ambitions that sort of, they're not really...
I think we need to come from the area to know the area.
To know your people.
Yeah. Does Elaine want to come in there?
I don't know if this is on. Yes, it is. Sorry, not holding it near enough. The connection with Julian, thinking about how we move this going forward is really important. Yeah. But perhaps at the end, could we just have a talk? Because maybe between myself and our PALS representative, we could look. Because if the person you're talking about right now needs the help, we need to do something about that now. So if you wouldn't mind waiting.
She's received the help. She's received the help and somebody's kindness by allowing her into their yard. You know, I saw her yesterday and she was sitting on a trailer step with her head in her hands, obviously distraught with pain or whatever, you know.
But if you don't mind
But it keeps happening.
Yeah, if you
I don't mind. I'd be delighted. Thank you. Thanks so much.
Thank you. Any more hands? Lady in the middle here? Is it?
Just to say, perhaps this illustrates the frustrations we have sometimes in the community. There are too many tiers. I'm sure all the people on the panel are very committed people to what they're doing and what organizations they belong to. But there are too many tiers, and as I understand, there's another tier to come on top of you now. There are too many tiers to get something done, because in the former days or so, you knew exactly you could go to the GP or to the district nurse or so, and something was done, because they knew that was going to be taken into hand and led to the next person up, and then it was finished and it was done. But today, it's impossible, because there are so many tiers you have to go through. And the people who actually give the care on the bottom, they have no authority or authorization anymore to actually act and decide for themselves, because they deal with the patient and are there day by day, possibly, and they can't do anything because they have to report to the next person on a committee or so in order to get it done and authorized.
I think you know, one of the key things here is talking about our integrated care teams and how they work, and indeed how we need to expand and develop those as well. And I think that's absolutely the right direction of travel. We realise that different organisations don't often talk to each other and communicate. We need to make sure that works better, and the PRISM teams are starting to do that by having, you know, social care very heavily involved within the healthcare, with mental health on board there as well, with the voluntary services coordinating things as well. There are no more tiers to come above us. If anything, actually, there's less tiers between us and sort of central government coming in the next year or so. I mean, post-election, who knows? But certainly in this next sort of year or so, the plans are that less tiers are going to be above us anyway. And I think one of the absolute fundamentals about clinical commissioning groups, as I mentioned in the films there, is actually that the people that are doing the jobs, i.e. the doctors, the nurses, are actually well connected with the CCG. As I say, you have to be a practicing clinician to be the clinical chair of a CCG. I still do 3 full days within practice each week. I'm a practicing partner, so I have a share in the business. I understand the risks of my business. I still see my patients. I actively manage my patients. I understand their issues. Our governing body clinicians, they're all, again, practicing GPs who spend more of their time as GPs as they do, you know, as working for the commissioning group, so they understand the issues. We're increasing our membership in terms of some of our clinical executive committees to take on board more nurses, more allied health professionals such as physiotherapists, OTs. We've got pharmacists on board as well. So we're actually opening the doors to make sure that those people that have that first contact with patients are actually in the middle of the influencing groups that can change things. I'm absolutely not saying it's perfect, okay? But what we're doing is trying to move it on to something where it is more perfect and better.
There's something else. I just wonder if somebody, I don't know who that could be, from the committee or so, could get and start planning with the local transport services.
Mm-hmm. And that's part...
Because
yeah.
people who are up in Mansfield or so, they take up to 4 to 5 hours to get there and then come back again, not to talk about.
Yeah. That is actually a separate work stream as part of the Better Together programme, is looking at the transport links and how we can better that as well. So that has been picked up. It is work in process, but it is something that we have identified from listening to our patients and public that needs to be sorted out, so it is being taken forward at the moment. Okay. Lady over here, down on the 3rd row.
Mental health has been mentioned twice to you. It looks like we are going to potentially lose Enright Close and the 24 beds there. Can you tell me, have you made any representations on behalf of the local people here to Notts Healthcare to retain those beds? Can you tell me if you've actually done anything to retain mental health beds in Newark?
Amanda, do you want to say you're okay picking that one up?
Yeah, hi. I I think we have to think about the, if you like, where that work has come from. I think you'll remember that several years ago there was the Winterbourne View scandal where patients with long-term mental health or learning disabilities were kept in small hospital environments for years and years, and that sort of triggered a review across the whole of Nottinghamshire for people who were living in institutional settings to see whether that actually is the right thing, whether people are getting the right rehabilitation or whether they're essentially living in an institution when they could be living more fulfilling lives outside. And we know from bitter experience with the Winterbourne View that it can be a very bad thing, and they can be very bad environments in an institutional setting. So a big review has been carried out over the whole of Nottinghamshire over the past couple of years, including down to looking at each individual resident within those, or patient within those settings, to see how many did really need to be in those settings. And actually the ones that were, rather than them being there for 10 years or 20 years or however long, looking to see whether we could do better, give them better sort of treatment, if you like, to rehabilitate those people and get them into a community setting. And when that review took place, it was very much along the lines of, we don't want people in institutional settings if they shouldn't be in there. If they do need to be in inpatient beds for 20 odd years, then that's right and proper, but actually a lot were getting stuck and losing a lot of confidence in the outside world. So across Nottinghamshire, all of the individual people in those types of areas were assessed, and the Enright Close facility was a particular facility where the clinicians felt that actually those people would be better cared for by being out in more of a supported living type environment with community support, rather than being in very long-term institutions, which, bitter experience over time has told us is a bad thing. So that's why the Enright Close was, if you like, earmarked for those beds to be, over time to be closed, and that's why the consultation took place. The CCG was part of that review, and we supported the idea that actually you shouldn't have people in institutions if it's not the right thing. But we also support the idea that people do need the right mental health services and the right level of support, although the nature of that support will move from being in an institution to being in a supported living environment with the community teams. So we're supportive of the principle.
Can I just interrupt?
Yeah, sorry, should I just finish, and then if I don't answer all. I think what we are very clear about, though, is that if the Mental Health Trust is doing that, they need to make sure that the right support is available in the community setting. And we are saying to them, in principle, we agree, because it's the right thing for people to be in supported housing rather than an institution if that's right for them. But what we're saying to them is you need to make absolutely sure that you've got all the backup ready for those people in the community, and they are individually assessed and get the right package for them. We know that there's been some teething problems. They've assessed a number of people in there as ready to come out of that setting, and we've supported that with them, but we've said to them, you have to make sure you've got the right package in place. We do think there are some teething problems, and we're on to that with them. So the principle we think is right, but the actual physical support and practical support for people locally, it's not, so we can't be having less money spent on mental health services for Newark and Sherwood, but it needs to be spent probably quite differently. So we know that there are some issues about the support people are getting, whether they feel that's enough or not, and we're saying to the Healthcare Trust, you've got to make sure that's absolutely right.
I think just to say to you that when we went to the consultation meetings this last 2 weeks, what they were saying was that they do intend to retain 2 or 3 of their rehabilitation units, and it just made me wonder why they would keep these other units. But take away our local one. And whatever, you know, while I appreciate people say we do not own Enright Close, it's owned by Notts Healthcare, it is still a local service that we are losing, and Enright Close is set up to look after people. We had previous former patients at the consultation, and some of the discussions they had were very, very relevant, and they were concerned that although you talk about people being institutionalized, these former patients didn't feel that at all. They felt secure, they had friends, they had support, they could live in their own private area, but they still had the support when they came into the dining room and the living room. And that is what they wanted. And when we're talking about people with mental health problems living in the community, you know, what these people were suggesting was that in many cases with putting people into a community, however it is, a room or a bedsit or whatever, actually can cause people to feel very isolated and away from the support that they need. And I just think that it is another service that we are losing, and what I'm saying is, what other services have we got in Newark that would look after people who don't need to be taken in an ambulance over to Nottingham for, you know, some severe care? People often need an inpatient care, and that place is set
Amanda,
up for it.
can I just ask Amanda maybe to sort of answer that if you can, because I'm just very conscious of the time.
Absolutely recognise that when people have been living in an area for a long time, it feels quite unnerving and isolating. Sometimes it can do, which is why we have to make sure that people do get the right level of support. I think in terms of why it was Enright Close, I think it was because a lot of the people living there were, when the clinicians assessed them, were sort of felt to be really ready for discharge, and it was the type of facility. It wasn't really adding the sort of clinical value, if you like. So we do need to make absolutely sure people are well supported. In terms of losing a local facility, as I say, we need to make sure that the investment is reinvested in the local community. The Enright Close wasn't necessarily a local service, so there were people in there from all over Nottinghamshire, so it's not that it was a Newark service that's been lost, it was a service located in Newark that served a much wider area, so it is only a very small number of people, but all of those feelings and thoughts that you expressed are really important, and we need to make sure that those people are properly cared for.
Thank you. I'm aware that we've actually run over time, so apologies for that. So I am going to wrap up the question and answer session now, but we will be around for a while afterwards, so if anybody does have any questions, then please do come to us and have a chat, or otherwise contact us through the CCG in whichever one of the means you'd like to, and we can discuss things in more detail. I would like to thank you all very much for attending today. I think, as I said at the start, it is an ideal opportunity to listen to what we've done and where we want to go, and also provides you know, a forum that we can listen to feedback from our sort of patients and our public as well, to take ideas across. As I say, the absolute key here is to make sure that we are listening to patients, so any feedback that we can take from you will be much appreciated. And again, whether it be today or otherwise, sort of through the CCG, through the website, through any of the other media that we use, that would be really, really much appreciated. Thank you very much indeed for attending, and have safe journeys home. I'm going to throw the floor open to members of the public. Anybody interested? If they have any questions, and we'll see, do our best to actually answer them for you there. So, hands, show of hands across the back there first.
Yeah, I am involved, both locally and nationally, The one thing I did notice, or didn't notice, shall we say, in the whole of the presentations, was out of hours. I've been living with a long-term condition for 25 years, and it doesn't just start at 8 till 5. So the out-of-hours service, I see you've got the flow, and I know all about flow, but people here might not. So I think you've missed an opportunity of explaining that.
Yeah, I think that's a really, really valid point. Thank you for bringing it up. Throughout a lot of the work we're doing across PRISM, so that's the integrated care teams, but also working on the primary care strategy, we're absolutely looking at how we can improve the provision of service out of hours. We very much appreciate, as a GP, you know, I realise this in day-to-day practice, that patients just aren't unwell between 8 and 6:30. Patients become unwell overnight or at weekends and bank holidays as well. We do have an out-of-hours service that provides GP cover during those out-of-hours, but actually what we need to absolutely do is make sure that the offer that we're giving to our patients is really robust. Patients have a plan so that they know what to do if actually out of hours they do become more unwell. And that's not just patients that, you know, are acutely unwell as a random type of thing. That's patients that have a long-term condition that, you know, potentially are going to become unwell at some point as well. And that's about drawing together lots of different services to make sure that our offer is the best it can be. So a few of the things that we're looking at the moment is trying to make sure that wherever possible, and if patients give us their consent, we can share their records. So if they were to access a service out of hours, it would mean that either our out of hours GP service or the East Midlands Ambulance Service or the hospital trust could actually have a look at that patient's records to say exactly what the conditions were, what medications the patient's been on, what's recently been happening, what investigations have been done, so there is no duplication, to try and make sure that the best action can be given at that particular time. We're also looking at how we can provide more of the local trained GPs to actually provide out-of-hours cover, both over at Newark and also across at Sherwood through Kingsmill Hospital as well. So that actually, if you were to end up in one of the emergency departments or MIUs and you had a primary care problem, you would be seen by a local, well-trained doctor who could actually get you sorted, give you a plan to stop you bouncing around the system. So we are working very hard on that. A lot of this is covered in the primary care strategy, but absolutely, thanks very much for the question and raising it. We are really onto that one.
Next question. What's this about the new ambulance protocol? Bearing in mind I saw recently EMAS had an average call-out time hour and a half, for example.
Sorry, in terms of the new ambulance protocol, do you want to just clarify?
The ambulance protocol, what is the protocol? Bearing in mind I've heard recently that the EMAS call-out time is probably average an hour and a half.
So this is this is the ambulance protocol in terms of which patients can be taken to Newark Hospital. Yes. So
prioritising patients.
So as part of working on the Newark Hospital Vision and Strategy document, we received lots of feedback in terms of certain conditions that potentially could be treated at Newark that were being taken to other emergency departments such as Kingsmill or Nottingham or Lincoln. Now, absolutely, we must work to make sure that those patients receive, you know, first-class care in the best possible place. It's difficult sometimes because actually the call is made and the presentation means that sometimes things do get worse and situations can escalate. So that means that not everything can be taken to Newark Hospital, and this is one of the major reasons that we did the reclassification work with Newark Hospital, recognising that patients who are unwell, where we don't have a diagnosis or the potential for that patient to get worse, we do not want to be unsafely transferring to another centre, possibly being ventilated or being resuscitated. So it's absolutely about getting them there the right place the first time. However, we do realise that there are patients that potential ambulance is called and they can be treated at Newark Hospital. So some examples there are patients that maybe have fallen over that we think have got a less major fracture or a less major injury that might just need x-rays to confirm that everything's okay, and then, you know, some treatment can be sent home afterwards, that they don't need to go across to one of the bigger hospitals. So this new ambulance protocol looks at what particular injuries or problems that the ambulance service can go and pick up that can be taken to Newark Hospital. Now, clearly, if people are being taken to Newark Hospital as opposed to actually taken to one of the other centres, it means that it does free up ambulances, and we should hopefully see some increasing improvements in those response times. The difficulty, as I say, is not always clear-cut, and clinicians and the public, we had a long chat about this in terms of what particular conditions can be seen. Somebody who becomes unwell collapses 3 or 4 days later, after quite a lot of investigation and treatment, it might be that they've had a urinary tract infection causing it. We don't know that at the time. It could be a stroke, they could have fallen over a few days before and had a head injury and a bleed, they could have had a heart attack, they could be developing a pneumonia. So it's very difficult to try and make sure we have an absolutely robust protocol, but as much as possible, we've made sure that whatever can be treated at Newark is taken to Newark. That will, continue being refined and observed, because the key here is that we don't want people in the wrong place and we don't want those unsafe transfers.
Just to pick up also on your point about an hour and a half call-out time, I think what that's referring to is not that it takes an hour and a half to get to the person on average. In an emergency, the actual achievement for the Newark area and surrounding areas of getting there in an emergency is such that even if it misses the 8-minute target, it only just misses the 8-minute target. So people with emergencies aren't waiting an hour and a half. The hour and a half figure has been used to refer to the time between the call and then to when the ambulance is free for the next call. So that includes the getting to the scene, treatment and assessment at the scene, which often is the majority of the time, taking the person to wherever they need to go if they need to be conveyed to hospital, and then having handed over that person in the hospital, and then having washed down the ambulance and being sort of registering as being ready for the next call. So in emergency situations, people aren't being left an hour and a half. Sometimes when it's a lower level of emergency, it's not really an emergency, and they are on quite a low priority in terms of clinical safety. That's when the longer ambulance times have been reported. And obviously we're trying to improve those, but in real emergency situations, people aren't being left for a long time before they get any help.
I know, dwell on a point, for example, I did remember reading, on Tom Muir, I did remember reading pieces from a lady from Farnham who was left in the gutter for 5 hours due to EMAS indirectly. So that's good clinicians, with regard to what you're purchasing. And that's, for example, with regard to EMAS, are you not prepared to purchase the ambulance service from other people, i.e. Arriva or St John's perhaps? Is an alternative person available to provide that service?
We do already commission transport from Arriva, who supply us with patient transport, which isn't the sort of full ambulances. And St John's Ambulance as well do contribute as well, and EMAS sort of have worked with St John's Ambulance to improve. So really we do use all of those, but all for the bits that they're sort of expert in, really. Yeah.
Coming back to what you're just saying, I've actually been taken on Hospital 999 on St John's Ambulance, and I thought very good, but no respect to EMAS, waste of time.
I think one of the other things that we're doing as well...
That's my experience, sorry.
I think one of the other things we're doing is trying to work with the ambulance service to try and make sure that we're using the service as effectively as possible. So actually, one of the ones that we're doing there is we've commissioned a sort of an urgent ambulance for the sort of Newark and Sherwood area. So patients that potentially will need transporting to one of the hospitals, or indeed actually who, for some reason aren't able to actually get down to a GP surgery if the ambulance is there, we're actually using this ambulance to convey the patient. So it's not for the blue light, for the full resuscitation, for the sort of the hot emergency, as it were. But for example, if I go to see a patient, and they do need an admission to hospital for something, but a couple of hours is fine, etc., then we're actually paying and commissioning a service from EMAS to make sure that we have a service that just is particularly for Newark and Sherwood. So we're not almost at the hands of the rest of Nottinghamshire or the East Midlands in terms of that. And obviously we'll continue to make sure that if we have got local initiatives that we can use there, we will do with it.
Can I just ask about improving the links between hospitals and GPs? If I use an example, and Elaine, I've asked this person if they relate this story, good and bad, mostly good actually, but doesn't want to, unfortunately. So fell over on an ice cream spillage in Victoria Centre in Nottingham, 74 years old, breaks a hip, Queen's Medical Centre, week, lives on his own, goes home, after a few weeks starts feeling unwell, found the following day collapsed on the floor by his daughter who visits every day about lunchtime. Blood clot into Kingsmill, another week in hospital. Just a small aside here, just comparing the two. Thought the food in Queen's Medical Centre was absolutely dreadful. Thought everything in Kingsmill was wonderful, apart from some of the staff who had a problem understanding sometimes. He's Scottish and I have a problem understanding him sometimes. But generally, comparison between the two, both extremely positive. The bad bit was, the team in Kingsmill said it was not highly likely, but quite probable that you would have this kind of problem after a large operation like the one you had on your hip. Didn't anybody tell you that if you were feeling unwell to kind of look out for it? No. So he'd been feeling unwell for a couple of days, but because nobody had mentioned that he might feel unwell and he might possibly get this kind of problem after the operation, has left it probably too long to the point he collapses and finds himself in a fairly serious situation. How do we improve that link between the two?
Yeah, I think that's a really important point, actually. And actually, Elaine's the expert on these things, but actually one of the big drives in the NHS at the moment is trying to prevent blood clots, whether they be in sort of legs or lungs, and hospitals and general practice do a lot of things to try and prevent them. Yeah, that chap should quite rightly have been informed about this, and indeed I know that sort of patients coming out of Kingsmill now, and they actually come out as part of their sort of discharge package. Not only do they have their list of medication and you've been in hospital because of, they also have just an A4 side piece of paper with bullet points about sort of things to look out for in case potentially to try and avoid or get help early with sort of blood clots, etc., etc. So certainly I think that's something that's really important. Again, communication is important between the hospital and the GP as well, and that's something we're working really hard on. Because believe it or not, often, the first we know that the patient's been in hospital is when they tell us themselves, or a relative tells them, and we're working really hard on electronic ways of actually sharing information and making sure that as that patient walks out of the door of the hospital, we know that they've been in, we know what they've been in with, and we know that we're looking out ourselves for it as well to absolutely make sure. But I don't know whether Elaine wants to speak a little bit more about sort of...
If that's okay, because we've had a conversation before, but perhaps just to take that slightly wider, because Mark's right, there's lots of work done, and there is a national standard about people being assessed, treated, etc., and should be getting information when they go home around potential clots. But I think for me there's also the broader bit in your question of sort of irrelevant of what the sort of concern was, an issue for the individual, that bit about good information, whether that's information at discharge or information when people move between services. And one of the things that we've done this year is start to put some challenging through our CPRIN, which is one of the sort of quality standards within our contracts, at getting people to, the organisations to review their internal processes around sort of transfers and discharges. And in this coming year, what we're doing is starting to strengthen that, to look at both that information, both to the individual who is being either discharged or moved between services, but also the organisational information. Because again, we do get a fair bit of sort of feedback that shows us where that kind of information sharing is not exactly where we would want it to be at best practice level.
A couple of other things, if I may as well. I mean, one thing that we're working hard on as well at the moment is trying to make sure that when a patient gets pushed or walks through the doors of an ED, wherever that be, that the GP is alerted automatically to that. because actually there might have been a lot of hard work going on in the community with that patient, and so it's a case of, well, hang on a minute, why are they there, what's happening? You know, it might well be very much that they need that urgent attention, but it might be that there's been a failure somewhere in communication or planning, and very quickly we can get that patient turned around and coming out again, or at least, you know, give more information to the hospital in terms of the plan and what's been happening with it. So we are currently working on IT solutions, sharing information, so that almost the on-call GP of the day flashes on their screen that, you know, Fred Bloggs, you know, has just been put into ED at Kingsmill, you know, so we can actually do a bit of exploring there and try and work out why. It might well be that we can give information that helps the admission. It might be that we can get the patient out much quicker as well. And the other thing that we're doing as part of the prison teams as well is working with our partners in county health partnerships to send our community matrons into the hospitals as well. So they're actually roaming around in the emergency departments looking at our patients, seeing why they're there, which patients that we can get some planning in and get them out early, but also roaming the wards as well to actually have a look at what patients are there, why they're there, what are they waiting for, what's the problem that they're still in hospital for, can we get them out quicker, can we do these assessments at home? And it's quite amazing actually, I think, the difference in terms of the staff between community and secondary care as to sort of the thresholds for safety and what people feel are safe and are not. And I think by sending our community matrons in, I think certainly the hospital staff are starting to realise about the complex patients that we can manage within the community. So I think in terms of that integrating care and breaking down those boundaries between sort of primary care and secondary care, we're starting to work for the best of the patients. It's work in progress, but we're getting there, we're moving on with it. Lots of information sharing and sort of lots of further bits to go with it there, but hopefully we're on track there with it. Question up at the back there.
As we're talking about saving, you've mentioned quite a lot of ideas and new things happening. But one very simple one that occurred to me recently when I went into hospital was medications. I was given a particular medication that I was told cost £500. I kept it in my fridge for a long time, and I tried all kinds of avenues to do something about this and try, and it wasn't opened, it wasn't nothing, absolutely nothing, well in sell-by date, and no one wanted it. And if you go to the chemist, I'm told, it's thrown in a basket. Now surely, as a housewife, I wouldn't throw away a very good item in my pantry. I'd use it somewhere. And I think if you're trying to save money, then that is one area that needs to be looked at, I think.
I think that is a point really well made, and actually any of the CCG staff that have sat in clinical meetings with me, any of the pharmacists will know that this is actually one of my sort of bugbears, is actually the amount of waste that's sitting out there. You know, we're working really, really hard to try and absolutely make sure that, you know, every penny is spent in as an efficient way as it can. But I know as a GP, you know, it's patients going to hospital, but it's also patients sitting at home for whatever reason, whether it's pharmacies ordering inadvertently or patients ordering inadvertently or the practice inadvertently giving out prescriptions. I'll go on home visits and patients have got cupboards full of medication, you know, sort of black bags full that we send the pharmacists around to collect there. And I think it's a real difficult one. There's so many prescriptions floating around there and so many ways that actually they sort of, you know, can be ordered and distributed. And as you say, some medications are very expensive there that we need to get much better at trying to sort of tighten all that up. Really pleasing that recently we've had John Reynolds, who you saw there on the second film, who's one of the local community pharmacists from Newark. He's actually joined our clinical executive committee, specifically so that we can actually have a look at how we can work harder with community pharmacists and chemists to try and make sure that we're effectively prescribing, but also absolutely making sure that we're saving money where we can and also reducing waste. And our prescribing team, Michael's here today as one of our prescribing team, looking at other ways about practices and how they can actually limit supplies, but also talking to chemists about things, you know, sort of can be changed around. The difficulty about the not being able to have it reused again is a problem. Clearly, it's safety. So actually, once it leaves the chemist or the hospital pharmacy, even though it's sealed, there's still a potential that either it's not been stored properly or it's been tampered with. So these sorts of medications, once they actually leave physically that building, unfortunately, they can't be used again. So it's all absolutely about making sure that only the right medication goes out in the first place so that we aren't wasting it needlessly. But it's a really, really important point. I've been banging on to our teams about it for a good few years now. I think we're getting better at this. We've still got a long way to go though. Any other questions? No? Last chance? Okay. Well, thank you very much indeed for coming. Really appreciate your attendance. I hope that's just given you a summary of what we've been doing over the past year or so, and also help people understand a little bit about the future work. As Elaine said, lots of different ways you can get in touch with us. So if you do have any questions, concerns, stories you'd like to share, either positive or negative, we do learn from them, we do listen to them, we can respond to them. Please do shout up or get in touch with one of us. But thanks very much indeed for coming, and have safe journeys home.